Thank you, the organizing committee, for allowing me to make this presentation. So this morning, I'm going to speak about the COVID-19 pandemic and psoriasis. So in December of 2019, there was an outbreak of a highly contagious severe pneumonia that was reported in Wuhan, China. And the causative organism was found to be a severe acute respiratory syndrome coronavirus 2, the SARS-CoV-2. This is a highly pathogenic and transmissible virus that is spread through respiratory droplets and close contact. WHO thereafter declared a global pandemic on the 12th of March, 2020. And what has been found is that COVID-19 has effects on the morbidity and mortality of various chronic conditions, including psoriasis. And already Dr. Gakuru has mentioned the various comorbidities that affect our psoriasis patients, and they often are thought to have an increased susceptibility to COVID-19 infection. So there is some research ongoing to see if there is an overlapping immune pathway between the psoriasis and COVID-19. So a brief pathogenesis of psoriasis is thought to be triggered by various factors that cause damage to the keratinocytes. There are antimicrobial peptides that are released by the damaged keratinocytes that stimulate the toll-like receptors, and then which then activate the plasmacytoid dendritic cells to produce interferon. This interferon signals activation of myeloid dendritic cells, and there's differentiation of Th1 and Th17 cells that produce cytokines, the interferon gamma and interleukin 17. The activated myeloid dendritic cells will secrete TNF alpha, interleukin 23, and interleukin 12. And these interleukins further cause differentiation and proliferation of Th17 and Th1 cells. So this inflammatory milieu of cytokines and the interleukins will activate keratinocyte proliferation, and these keratinocytes also contribute to this inflammatory cascade by producing various cytokines, chemokines, and the AMP secretion. So I've highlighted some cytokines there: interferon, TNF alpha, interleukin 1, interleukin 6, and the TNF alpha. So the SARS-CoV also was found to enter the respiratory cells. It binds to the angiotensin converting enzyme system and activates the Th1 lymphocytes. And this produces a cascade of pro-inflammatory cytokines. And you may notice highlighted cytokines there: interleukin 6, TNF alpha, interleukin 1, and interferon, which are similar to the ones we've seen in the pathogenesis of psoriasis. So what scientists are now researching is these overlapping cytokines. Could psoriasis therapies, particularly the biologics, have a way of reducing the cytokine storm that we've seen causing a lot of mortality among the COVID-19 patients? So those are thoughts that are ongoing, and research is still ongoing on that. So what has been the impact of COVID-19 on the clinical course of psoriasis? So during the pandemic, we saw hospitals getting overwhelmed, even in our own country here. And therefore, the healthcare services were focused on managing the pandemic. What this caused was that there was limited access to healthcare facilities, and non-psoriasis patients missed their appointments, getting drug refills. New cases were delayed in getting a diagnosis because they were not coming to hospital. And therefore, there were severe flares in the known cases and a worse disease presentation in the new cases. There was a stay at home and lockdown orders, and patients therefore avoided coming to hospital, and therefore more severe disease at the time of presentation. So what can we do to solve this impact? We can utilize telemedicine in known stable psoriasis patients. We can provide guidance to our patients on how to minimize risk of getting infected with COVID-19. There was a lot of anxiety around that. And we can give prescriptions that last a longer time, 90 days, and therefore the patient doesn't have to come to hospital so often. COVID-19 has also had an impact on psoriasis therapies. We have 1 in 6 patients, psoriasis patients, who have disease severe enough to necessitate use of systemic immunomodulatory agents. Around this time, there's been a lot of fear whether these agents are going to make the patients more susceptible to COVID-19 infection, whether they'll have an increased persistence of the COVID-19 infection, particularly with the classical immunomodulators, the methotrexate, cyclosporin, and so on. And people have also wondered, is there an impaired immune response to coronavirus when a patient is on these immunomodulatory agents? We also use shared phototherapy chambers in the hospitals, and there's been concern whether there will be an increased risk of spread of the coronavirus when you share these chambers. So what we can do is, with COVID-19 negative patients already on psoriasis therapy, we should not stop the systemic immunomodulators because there is a risk of severe psoriasis flares if you stop these therapies. And also with the biologics, you should not stop the biologics, because when you stop them and you want to reinitiate, often there is a kind of resistance and reduced response, and you may need to change to a more expensive agent. For new patients, we can use agents such as acitretin and apremilast, which have minimal immunosuppressive effects. And for patients requiring biologics, you can use the interleukin 17, interleukin 12, 23, and interleukin 23 inhibitors, which have been found to have a lower risk of infection. There has been a suggestion to suspend use of shared phototherapy chambers, and patients who can get home UVB kits and use natural sunlight. For COVID-positive psoriasis patients, we are to hold systemic immunomodulators during the active infection until the COVID has cleared. There is a caution with use of Janus kinase inhibitors because they have been noted to cause a downregulation in cytokines that are critical in lymphocyte development and response to bacterial and viral infections. So these ones, you should exercise caution and, if possible, avoid them during this pandemic. So COVID-19 has affected the quality of life of our psoriasis patients. The DLQI is one of our indicators we use to assess severity of psoriasis. There's been a lot of emotional stress during this time, job loss, restricted activities, loss of loved ones, and a lot of depression and anxiety, as Dr. Gakuru has mentioned. So what we can do for our patients is provide up-to-date information so that they're aware of what is going on, what they can do to protect themselves. Offer psychological support. Often psoriasis management goes beyond just writing the prescription. Take time, speak to your patient and address their concerns. Give ideas on stress reduction techniques, exercise, meditation, yoga, and connect them to support groups such as the Psoriasis Association of Kenya that has continued to support patients within our country with psoriasis. So what about psoriasis and the COVID-19 vaccines? There is no contraindication for COVID-19 vaccination in our psoriasis patients. No need to interrupt systemic therapy to give the vaccine. Do not discontinue biologics. It's thought that the patients may have a diminished immune response, but the effect of this is not known. And therefore, patients to still exercise, protective measures, use of masks, hand washing, and so on. Psoriasis patients are thought to be already in a high-risk group with their comorbidities and the therapies we are giving them. So they definitely need to be vaccinated. And the benefits of the vaccine outweigh any risks that we may be concerned about. The effect of the vaccines on psoriasis treatment is unknown, and there has been no evidence that the COVID-19 vaccines affect the course and severity of psoriasis. So these are some 2 case reports. There's still more research going on the link between psoriasis and COVID. So the first was a new onset of gutted psoriasis after COVID-19 vaccination in a 79-year-old lady, diabetic, who received the Pfizer vaccine, developed gutted psoriasis-like lesions. These resolved after use of a topical steroid, but when she received a second dose, she got the lesions once again, and on histology were confirmed to be psoriasis. The second case was guttate psoriasis secondary to COVID-19 in a 39-year-old male who had stable plaque psoriasis, a solitary plaque on his leg. And when he developed psoriasis, 6 days later, developed these guttate psoriasis lesions that were confirmed on histology. So there's a lot of research that needs to go into what is the link between the vaccination and in general COVID-19 and psoriasis. So in conclusion, COVID-19 may persist for years to come and may have a long-lasting impact on the clinical course and management of various skin conditions, including psoriasis. Our healthcare practices need to change and must be made to optimally care for psoriasis patients who require regular reviews and follow-up. It is important that we manage our patients on case-to-case basis, as Dr. Kariuki alluded to, and a lot of shared decision-making when you're offering treatment, considering patients' age, comorbidities, and so on. Always weigh the benefits of our actions against any potential risk, and that more research is being done both on psoriasis and on COVID-19. Those are my references. Thank you.